Services Director at the Masonic Cancer Alliance. I want to welcome you today to the first in our 5-session webinar series of Cancer Screening and Prevention and Action, funded through our partners at the Kansas Department of Health and Environment at KDHE. So I want to get us started today by talking a little bit about continuing education. If you would like continuing education or a certificate of your attendance today, you can receive that by first being sure that you have your full name listed on your as a participant. So if you don't currently have that, so you see my name there, here's one way that you can change that by going to the participant list at the bottom of your screen. And if you hover your mouse over, then you can choose to rename yourself. Tracy has some information in the chat in case you're watching this with any colleagues. We will have continuing education credits for physicians, nurses, and social workers, and certificates of attendance available to any other participant who would like one. We have a few disclosures to make here, and you'll see there was a disclosure by one of our planning committee members and one of our presenters. But all financial relationships listed have been mitigated. These are the objectives for today's session, and we have some objectives for our whole series as well. But for today, we will spend some time talking about activities completed and process changes implemented to improve lung cancer screening rates, how to apply those strategies to enhance and increase lung cancer screening efforts, and to identify the link between and the benefits of concurrently dealing with smoking and elevated radon exposure. To document your attendance today, you will, after today's session, you can go to eads.com, so either through their website or by using this QR code, and you'll put in the session code 52GENT, so 52GENT. You must enter that sign-in code by next Tuesday, November 26th at 12 p.m., so you have about a week to enter the sign-in code and complete the course evaluation for you to get that continuing education credit. This project was funded by the Centers for Disease Control and Prevention and the Kansas Department of Health and Environment, with some additional support from University of Kansas Medical Center and the Masonic Cancer Alliance. So I wanted to really quickly go over our series agenda. So you see, I mentioned a minute ago, we have 5 webinars, and then we'll have office hours after 3 of our webinars. So you'll see our next, so we're here today, November 19th. In 2 weeks, we will have office hours. So if you leave here today thinking, wow, this is all really interesting, how am I going to put this into action in my organization or my clinic? And I want to kind of figure that out. You can come to our office hours to get some additional technical assistance and have some conversations with your peers. I'm not going to go over each of the sessions that follow, but you'll see we have dates set for 3 additional sessions, including office hours after our HPV session in January. And then we have our March session, which the precise date is TBD. We hope to also have that on a Tuesday at noon. We'll have a session in May, which we will announce later, related to sun safety and skin cancer. Today, I'll finish up in a moment with our introduction to the series and to today's session. Dr. Michael Gieske will be presenting on lung cancer screening, and Christina Snyder will talk with us about radon and lung cancer. And then Brenda Stokes will finish us off talking about a project at her clinic in improving lung cancer screening rates. So I wanted to set the stage and first thank our partners at KDHE and Dr. Ahmed Ismail for his slide here and help us to look at lung cancer rates. So at the very top of the slide, we have rates of new cases for men and women, and you'll see that lung cancer is the 2nd most common cancer in Kansas. And then if you look at the bottom of the slide, you'll see that even though it's 2nd most common, it's the deadliest cancer that we have right now in Kansas. Responsible for about 1/4 of deaths from cancer in Kansas. And then we can think about our lung cancer screening rates. And this data is actually the last data that we had as of October was 2021 data. So about 17% of people who should be screened for lung cancer as of 2021 were being screened for lung cancer. And if you're familiar with screening rates for other cancers or just thinking generally, right, that's a low screening rate and something that we definitely want to impact. And part of why this webinar is particularly important. I want to make a quick mention too. Our partners at KDHE are responsible for the Kansas Cancer Partnership. It's an organization that brings together individuals and organizations from across the state to share information and resources, working together toward the goal of reducing the burden of cancer in Kansas. So if you're here today and one of our future sessions and you think, I want to do more, I want to get involved, I want to be a part of this work toward reducing the burden of cancer, we'd love to have you join us. So there's a bit.ly code at the bottom. You'll see that. You can just, it is case sensitive. So if you write that down, be sure to add the capitals in the right places, or you can use your camera right now in your phone to click on that QR code. And there's a membership form that you can complete, and you can join us as part of the Kansas Cancer Partnership. So we have a quick poll that Tracy's going to pull up for us. And while she's pulling that up, I'll kind of read it. So we'd love to know how much all of you already understand about lung cancer screening. And so people should be screened for lung cancer once a year with a low dose CT if. And so you'll see these questions that are right here on the screen, and I'll read them for you. So if they're currently smoking and have smoked for at least 30 pack years, if they're between the ages of 50 and 80, are currently smoking or have quit in the past 15 years, and when they were smoking, they smoked for 20 pack years. If they're between 40 and 70, are currently smoking and have smoked for at least 20 pack years. Or the last answer is if they're between 50 and 80, are currently smoking and have smoked for 30 pack years. So I'm going to leave that poll up for just a couple of minutes. I see that about half of you have currently responded. So we'd love to hear from you. There is a right answer, but there's nothing wrong with not knowing the right answer, right? This is part of why we're here today, to help level the playing field. I'm going to go ahead and end the poll, and we can see what our results are. So you can see here on the screen, the correct answer is B, that people who are between 50 and 80 with a smoking history or currently smoking should be screened yearly for lung cancer. And so about of 49 people who completed it, it looks like about 38 of you knew that answer. So nice job, everybody. I'd like to introduce our first speaker, Dr. Michael Gieske. Dr. Gieske comes to us, this will be the maybe third time I've heard him speak, and every time I leave with excitement and energy thinking about how I can impact lung cancer screening in our state. Dr. Gieske comes to us from St. Elizabeth Healthcare in Kentucky and is the director of their lung cancer screening program. Dr. Gieske, if there's anything additional you'd like to share about what brings you here today, I'm going to go ahead and let you drive your slides. Thank you.
Okay, perfect. Thank you, Karen. I thank the Masonic Cancer Alliance as well for this opportunity. And let's see if I can move my slide here now. Press the button and nothing's happening yet there, Karen.
You should have control. Let me stop it and restart it 1 second. Try once more. No? There we go.
Yeah, that might be working out. These are my disclosures. This is our team. We have 6 hospitals in our healthcare system in Northern Kentucky and Southeast Indiana with St. Elizabeth Healthcare. Our flagship new cancer center is already about 4 years old in Edgewood, and this is our new cancer center in Southeast Indiana. And St. Elizabeth Physicians is our physician group. We have over 820 providers, and we serve about 400,000 patients in our region. So I'm a family doc. I've been in practice for over 37 years now, and as I'm sure many of you all, when you hear the 2 words lung cancer, get a pretty sick feeling, visceral gut reaction, because lung cancer has historically been such a devastating cancer. It's not often, unfortunately, found until it's too late in stage 4. And it's an aggressive cancer, can move very quickly through the stages. And we're working really hard to flip that narrative. We got some ways now we can change the story and bring hope to those at risk for lung cancer and with lung cancer. There we go. So if we look at cancer deaths in the United States, lung cancer eclipses the other cancers, and it actually kills as many as colon, breast, and prostate cancer put together in the United States. Now, many states, including Kansas, it actually kills more than colon cancer, breast cancer, and prostate cancer combined. In Kansas, it's estimated to kill almost 1,300 individuals throughout the state of Kansas this year. And as we know, most lung cancer is due to smoking, and the smoking prevalence nationally is 13.5%. Kentucky used to battle with West Virginia for the bottom position. We're now pulling away. We're fourth from the bottom, so 20% of adults in Kentucky smoke. And in Kansas, y'all are at 15.6% of adults that smoke, a little bit below the average tier. When it comes to survival course, stage doesn't matter. We're trying to move folks from down here in stage 4, where the overall survival in stage 4 is about 4%, up in here into stage 1, when the survival can be greater than 90%. And these stats are quite old. They haven't been updated for a while. We really feel like it's quite a bit better than this now, but you can get folks a better than 90% chance of cure if you get them into early stage 1. You can't really talk about lung cancer screening without talking about the National Lung Screening Trial and its counterpart, the Nelson Trial, which was the study done in Europe and in the Netherlands and Belgium. The National Lung Screening Trial was the largest study ever sponsored by the National Cancer Institute, 53,000 plus patients over 33 centers. And the Nelson Trial is a very large scale trial as well, 16,000 patients. And this really put lung cancer screening on the map. It had a 20% overall reduction in lung cancer mortality in the NLST and a 24% overall reduction in the Nelson study, and actually a 40 to 60% reduction in mortality looking at females. So this is, of course, the scanner that we use for low-dose CT lung cancer screen. It's a simple test. There's nothing in you, up, you down, you through you, nothing gets squeezed. You're in and out of the machine within 3 minutes, and you're actually in and out of the whole department within 15 minutes, usually, if things are running efficiently. So it's a quick and painless test, very low dose of radiation. So you would expect we'd be knocking out of the park. We got a very deadly cancer. We got great research to back it up. We got a very simple test. Well, unfortunately, we're still kind of bouncing down around the bottom here. We've only gone up about 3.2% in the last 10 years looking at these specific studies. And this slide here was shown at the National Lung Cancer Roundtable a couple summers ago. And lung cancer is way down here at the bottom, and it just has been slow to take off. It's very different than the trajectories that we saw for breast, cervical, and colorectal cancer screening. So at St. Elizabeth, this answers the poll question. We started using USPSTF 2021 criteria in March of 2022, and that's 50 to 80 years of age. You have to have smoked within the last 15 years, and you have to have 20 pack years of smoking, which is a pack a day for 20 years or half a pack a day for 40 years. And it's an annual test. It's done every year until you either age out at 80 or it's been 15 years since you have smoked. Now, CMS, when they came along in early 2022, they used the same criteria with the exception of they only covered 50 to 77 years of age. So that 78 to 80 year age range is not covered. They felt that the evidence was not good enough to legitimize expanding the criteria from 50 to 80. So that complicates screening criteria a bit. So one of the foundational components of our screening program is our nodule review board. We meet every Friday morning, bright and early at 7 a.m., and we review all of our lung RADS category 4s, which are the higher risk lung RADS nodules. And then we also review the suspicious or incidental nodules that either the radiologist brings in by using a tag called Code Lung Management that they use, or that's brought in by our software, EON. And once these are brought to the nodule review board, the nurse navigator compiles the report. We have a radiologist, a thoracic surgeon, a pulmonologist there. We have our 3 full-time screening nurse navigators there, and I attend as well. We review anywhere from 35 to up to 50 nodules on a Friday morning. So once we get above 50, it gets a little tough to do it within an hour, but if everything's running very efficiently, we can usually do about 50 in an hour pretty easily. And these nodules are assigned a low, intermediate, suspicious, or high grade of suspicion, and then they're either set up for follow-up surveillance, referral to a thoracic surgeon, pulmonologist, or oncologist, or continued follow-up if they're already seeing a specialist. And the nurse navigator essentially holds their hand and guides the patient through this kind of scary, complicated process for the patient. They communicate with the ordering provider. They also communicate with any provider that the patient's referred to, and they coordinate the care and guide the patient through this whole entire process. Occasionally, patients are referred to a multidisciplinary tumor board, which meets every Thursday. This is what we call the Hawthorne effect. It's a study that was done decades ago that proved what we kind of already knew, that people's behavior typically tends to be better if they know they're being watched or monitored. And we rank all of our sites from top to bottom. We now have 41 sites, and we have about 200 primary care providers, and we rank them as well in a similar fashion from top to bottom. And we finished Q3 at about 40.9% of the eligible population. Our denominator is about 21,000. Those are patients in our system that are attributed to primary care providers that meet the criteria that we use for lung cancer screening, the USPSTF 2021 criteria. So if we annualize that out, we're tracking about 54.5%. And just heard a recent report, we're probably going to be pushing 55 to 56% uptake for the year. So it'd be really cool if we get it 60%, because that starts to get it in the ballpark of breast and colorectal cancer screening. So we finished 2022 at 44.1%, 2023 at 47%. So we're continuing to improve. And of course, that compares very favorably what's been the national average of 4.5%, according to the American Lung Association. Another foundational component of our program is our outreach specialists. These are RNs. We have 12 to 15 of them, and they work for what we call the Population Health Support Services. And they reach out to any patients that have had an outstanding mammogram, Cologuard, or mammogram, and we've added DEXA scans as well, that's been ordered but hasn't had an appointment or a completion. For lung cancer screens, if that hasn't been completed within 2 weeks, they reach out to these patients on the phone and try to get them plugged in with an appointment. Last year, they scheduled almost 3,400 lung cancer screens, and that's really gone a long way to improving our uptake. We actually presented in Austin, Texas last year for the ACCC, the Association of Cancer Care Centers, and won the Innovator Award. So this is our performance. We started our program in 2013. We did 7 screens that year, and we are on track to very soon do our 50,000th lung cancer screen. We're doing about 800 to 850 screens a month. Our October number is actually 904 screens. And we'll probably finish out the year just shy of 10,000 screens. We might hit 10,000 screens if we get 900 screens a month over the next 2 months. So not out of the realm of possibilities. That'd be cool if we hit that milestone as well. And this is just another way of looking at our progress. We celebrate our milestones as we move along, and it's great marketing and great attention for our program when we hit these milestones. We just hit our 400 stage 1 lung cancer in April. We're up to about 440 something stage 1 lung cancer since we started our program. And we have found almost 750 lung cancers now since we started our program. We keep track of all the cancers that we find through our program. This is what I call the compendium. Don't expect you to read this slide. There's a lot of data here. We track over 40 metrics. And with these metrics that we track, we generate, of course, a lot of data. And this is one table that we use. Again, it's a busy slide, but we keep track of our categories 1s, 2s, 3s, and 4s each year, annuals versus baseline, our lung cancers that we find, percentages of each lung REDS category that we find. And one of the things that's noteworthy is that for 2024, about 75% of the lung cancer screens that we're doing are now annual. So 25%, we still do a lot of baseline screens, 25% are baseline, But as your program matures, you begin to do more and more annual screens. And that's really when you start to see the rubber hit the road and make some significant improvements. We're finding one lung cancer for every 62 screens that we do. And we're finding one lung cancer for every 26 unique patients that we screen. So again, a very high yield test for a very simple and quick test. And it's not really the number of screens you do, of course, it's the results that you get. And we're finding 63% of the cancers that we find now in stage 1. And we're finding 73% of the cancers that we find in stage 1 and stage 2. Now, that's since we started our program. And that number has gotten significantly better over the last couple of years or so. In 2023, we found 144 lung cancers, and 72% of those were in stage 1, and 81% were in stage 1 and stage 2. Year to date, we're finding about 72.5% of our lung cancers in stage 1. This is a slide that's demonstrating the divergence of our baseline versus annual screens. The red line are our annual or follow-up screens, and these lines crossed in September of 2019 and are continuing to diverge. And again, really emphasizing the importance of getting folks back for that annual screen. This is always one of my favorite slides to show. This is looking at 4,000 lung cancers over the course of 9 years in our healthcare system, 2015 to 2023. The green bars are what happens outside of our screening program. And historically, about 50% of lung cancer is found in stage 4. And the blue bars are what happens in our screening program. So you can see it's better than the mirror image. And this is what we call stage migration or stage shift. Finding 115% more in stage 1, and we're finding 10.5% in stage 4, 77% less in stage 4. So in the state of Kentucky, some pretty neat things are happening here. For many years, for decades actually, late stage lung cancer, stage 3 and stage 4, was stable at about 80% without an appreciable decline for almost 100 years. And over the last 6 to 7 years, we've seen a 19% drop in late stage lung cancer. And that's almost exclusively due to improved screening in the state of Kentucky. So that prompted me to look at our healthcare system. And the blue line are the early stage lung cancers, which have continued to increase in number over the last 9 years. And the red line are the late stage lung cancer, stage 3 and stage 4. And those lines crossed in 2022. And we're now seeing more early stage lung cancer, stage 1 and stage 2, than late stage lung cancers in our healthcare system. We've had a 29% decline over the last 9 years. And that, again, is due to lung cancer screening and also due to an emphasis on our incidental pulmonary nodule program. We've really gotten pretty aggressive about going after our incidental pulmonary nodules as well over the last couple, 3 years. And I think that's a pretty good chunk of this decline as well. So when we look at national screening rates, this was last year's report from the American Lung Association. It comes out every November, and it actually just came out today with some information I'll share with you all. But last year, the national average for screening was 4.5%. Kentucky was number 2, which I was pleased with, and Kansas was number 15. The report that just came out today, I don't have a slide because I submitted this a few weeks ago, but Kansas has now moved up to the 14th position. So congratulations on that. And you're now at 18.7% screening. In Kentucky, they really changed the way they do this now. We actually dropped to 16th position. So I'm still kind of digging through the data and why exactly this happened, but there's a much greater emphasis on BRFIS data instead of the ACR, American College of Radiology Registry data. So this has really kind of been turned upside down. Totally different way of looking at things now. A few things about the future and some evolution of lung cancer screening. You hear a lot about biomarkers, and I've divided these up into kind of 3 categories to make it a little simpler. There's biomarkers for cancer prediction or predilection. There's biomarkers for cancer detection, which are body fluids, blood tests that are done looking for the presence of cancer that's in the body already. And then there's tests that are done for cancer direction, and this can be either a liquid biopsy or it can be a tissue biopsy. So we're doing some work with the International Agency for the Research on Cancer, which is a branch of the World Health Organization. We're looking at a predictive protein panel, and this is really looking promising. This measures the predictive risk for lung cancer. If you have a number of these proteins in your panel, then you're at an increased risk for lung cancer. And this can be used for selecting patients, for screening. It can be used for follow-up of patients or nodules to get a feel for what their lung cancer risk is. MCEDs, if you haven't heard about them, you certainly will. They're multi-cancer early detection tests. When you have a cancer in your body, it sheds DNA and RNA, it sheds cells, it sheds proteins and exosomes into the blood. And these could be measured through a blood test or through body fluids. And these cancers, through artificial intelligence, can be determined to come from a certain cell type, either lung, for example, or liver or colon. And we can now test for over 50 cancers with these multi-cancer early detection tests. And presently, only about 14% of cancers that are diagnosed are detected by the current screening tests. So when this technology is perfected, it's going to make a big difference. They're presently very expensive. They're not covered by insurance. They're not FDA approved. And there's a lot of questions around them still. The hope is that they can eventually increase screening rates for cancers for which we already have screening tests. But really, one of the things we have to prove is that will these tests reduce mortality for these other cancers that they're detecting, or could they conceivably cause more harm than good as we do the workups and investigate these blood tests? What are the false positive rates? What are the false negative rates? Ultimately, the public will certainly embrace this type of a test, and they are here, they are available. But the problem is that they have a very low sensitivity for early stage lung cancer with the present technology. And we really hope that that will continue to improve before it becomes more universally available. There's also single cancer early detection tests. Delphi has a test, First Look. It's a test that we did some research with them on, and it's showing some promise for looking at early stage lung cancers. They kind of place it like a Cologuard, where patients that are on the fence about getting a low dose CT lung cancer screen can get this blood test. And then if that's positive, then of course they move to a low dose CT. If it's negative, they return to annual screening. And these tests are going to really revolutionize lung cancer screening eventually when they become FDA approved. This is another test that we've done some research with. It's from a company called Nucleix out of Tel Aviv, Israel. A very accurate test. They're tracking to look at probably a greater than 80% sensitivity for picking up stage 1 lung cancer. So when we look at tests for biomarkers for cancer direction, about 10 to 12 years ago, 50% of tumors did not have a mutation that could be detectable. Nowadays, that's probably less than 10% of tumors don't have a mutation that can be identified. And a lot of these mutations have targetable therapies, and this is a list of them. And you've probably heard a lot of these: ALK positive, EGFR, NTRK, RET, ROS, HER2, KRAS. And these are biomarkers that when they're present, these can direct targeted therapies towards these mutations. And this is usually a pill you take once or twice a day. And this has made a dramatic difference in the survival for lung cancer. The other frontier is immunotherapy, and you've probably heard a number of these drugs through television commercials: Keytruda, Tecentriq, Imfinzi, Yervoy. And these drugs improve the body's ability for the body's immune system to fight cancer, and really amazing results with these drugs. The higher your PD-L1 biomarker, which is another biomarker that's measured, the better your chance of responding to one of these immunotherapy agents. Another pretty exciting field is ADCs, or antibody drug conjugates. What they can do is, you look at this yellow square here, this is a kind of traditional chemotherapeutic agent that's attached by this linker, this green bar, to a monoclonal antibody. And these are given by infusion. They go into the blood, and the monoclonal antibody specifically seeks out the cancer cells. So you don't have the generalized systemic side effects from the chemotherapy. They're taken into the cells. through an endosome, and then they lyse inside the cell and release the payload. They release the chemotherapeutic agent within the cancer cell. So it's a very targeted approach, and these agents are out there now, and lots of them are being developed. The other thing I wanted to touch on was a risk for lung cancer. If we look at the criteria that presently exist, they really only catch about 50% of the patients that qualify for lung cancer screening, or for lung cancer screening. In our healthcare system, about 43% of the patients did not meet criteria for the USPSTF 2021. So there's a lot of work still needs to be done with figuring out a way we can get to this other 50%. So 20% of the cancers that occur in our country occur in individuals without a history of smoking. Talked about our program. Radon's, of course, a big risk factor for that 20% that doesn't have a history of smoking. And we're going to hear a little bit about that shortly from Christina. In Asia and Africa, cooking oils without proper ventilation is a big factor. Family history is a very strong factor for lung cancer. Air pollution is a big factor in many parts of the world. And in Taiwan, is a different biology. 53% of cancers occur in individuals with no smoking history, and 60% unfortunately are found in stage 4. Globally, more than 60% of lung cancers occur in females who have never smoked. So there's lots of other risk factors out there. There's other risk prediction models that a lot of the rest of the world uses. In Canada, for example, and in the UK, they use this PLCO 2012 model. And it looks not only at the 5 criteria there in blue for what we presently use, but it looks at 6 other risk factors, including education, BMI, COPD, personal history of cancer, family history of lung cancer, and they look at race and ethnicity as well. This is a Venn diagram. On the right side is the USPSTF 2021. And the red circle there is the PLCO model, and it finds 20% more cancers when you use that model. So we're going to be eventually moving toward risk models. It hopefully will happen within the next 3 years, but sometimes the USPSTF and CMS doesn't move very efficiently, but we're hoping to see a little difference there. If you add a protein model to this predictive model, you find that the sensitivity can improve by 9.9%. So again, predictive protein models will probably be part of lung cancer screening in the near future. Another really cool technology out there is the Sybil product. It's a proprietary product that was developed by Leisha Sequist. She's a thoracic oncologist out of UMass that worked along with this engineering team at MIT. And what Sybil did, it was trained on the NLST scans, and they looked at those scans that develop cancer, and this technology uses AI that can see things that the human eye can't see. For example, on this CT screen on the left, it's seeing something in that red zone there that the radiologist human eye can't see, that suggests to Sybil that there's a dangerous spot there, and it can potentially evolve into lung cancer. And then sure as heck, 2 years later, a cancer shows up in this area. It has a 94% sensitivity in determining the development of lung cancer within a year. So this is something that'll definitely be utilized in the near future. We're hoping to get it implemented in our healthcare system soon. I want to talk about advocacy. Can't overemphasize the importance of advocacy. One of the advocacy groups that we work with is the White Ribbon Project, started by Heidi Naff-Mananda in the middle there. She was a fitness instructor, still is a fitness instructor. She never smoked, kayaks, bikes, climbs mountains, and one of the last people in the world you expect to get lung cancer, but she came down with lung cancer at 55 years of age, and it was incidentally found, and it had already spread to her mediastinum, so it was inoperable. And she was real frustrated by the lack of attention that lung cancer got, and the stigma and nihilism associated with lung cancer. So started the White Ribbon Project. We were the first cancer center to have a white ribbon build. She underwent chemotherapy, radiation therapy, and ultimately immunotherapy with durvalumab. And this is her scan now. This was 5 years after. She's now 6 years out from her cancer, and she has no evidence of disease. And these are the types of patients that are growing in number, and their voices are getting louder as well. We didn't have lung cancer survivors 10 to 15 years ago, but we have lots of them now that have had great results and are happy to tell their story. Want to mention briefly the HEDIS draft or the HEDIS measure. This is draft formation now. It's in development. We are an alpha and a beta test site at St. Elizabeth, and it's going to have two components, one component for tobacco use and another component for lung cancer screening. HEDIS measure stands for Healthcare Effectiveness and Data Information Set. And it's a metric that insurance companies are graded on. They put pressure on healthcare systems, who then put pressure on their providers to improve performance with respect to these metrics. Breast cancer screening, colon cancer screening, cervical cancer screening. There's a long list of HEDIS measures that presently exist. So lung cancer screening's been at a disadvantage not being a HEDIS measure, but it's coming. It's going to be open up for public comment in February and March. And hopefully by Q1 of 2026, we'll have this HEDIS measure in place, and that'll be a big game changer for lung cancer screening. Going to probably this Friday be presenting white ribbons to our top 10 sites in our healthcare system. Again, we have 41 sites, and this was a presentation we did a couple years ago, but the team really enjoys getting these white ribbons and being recognized for their top performance. We have white ribbons now shining on our hospital buildings and throughout a number of healthcare systems and buildings throughout our state. If you need any information about how to get one of these projectors, I'd be happy to share that with y'all. And that concludes my presentation. And my tagline is from the mountaintops, and literally screaming from the mountaintops. I take my white ribbon with me on all my backpacking trips and hikes, and trying to raise awareness for lung cancer screening and lung cancer itself. I appreciate this opportunity once again. Thank you.
Thank you so much, Dr. Gieske. Really appreciate your presentation. And we will, as we mentioned earlier, have time for questions of Dr. Gieske and all of our presenters in just a little while. I want to take the opportunity next to introduce Christina Snyder. Christina is the Associate Director of the Radon Program at Kansas State University. She's going to talk with us today about the health effects of tobacco, smoking, and radon. And Christina, you should have control of the slides now.
Oh, I do. Great. I'll go back there. So as Karen indicated, my name is Christina Snyder. I'm the Associate Director for Radon Programs at K-State. Part of what we do is a contract directly with the EPA to do outreach and education across the country on radon to all kinds of groups, including medical professionals like yourselves. So Dr. Gieske definitely covered the highlights, and there are some slides in here that I have that are old versions of the things that he's shown you. So this should be pretty quick. But we are here to talk about, well, I am here in particular to talk about radon. So there are many folks who have never heard about radon until one of us shows up and starts to tell you about it. But this is a radioactive soil gas. It comes from the breakdown of the uranium in the Earth's crust. So radon is present everywhere on the planet, indoors and out. Every building has some level. It is, unfortunately, you cannot smell, taste, or touch it, which means you have to test with a chemistry test and do some physics math in order to know what your level of radon is. It's not that it's not there, it's just that you have no way to sense it with your senses. Whoops, I've lost my button. There we go. So where is it? As previously discussed, it's everywhere. There are these maps out created in the 90s by the EPA. These are statistics maps. What these mean is that any county that is painted red in the map, it is statistically likely that any given house will test over 4, meaning a number of things. It could be geological. It could be a number of other things. We happen to live here in Kansas and Missouri, Iowa, Nebraska area in a section of the country that has quite a lot statistically. I should have looked up Missouri's numbers, but I did not. In Kansas, about 1 in 3 houses tests high. The yellow or orange counties, we would expect a radon test to come back between 2 and 4, and in the yellow ones, it's likely to be under 2. However, this is statistics based on the number of tests we've had, right? So in counties with very few houses or with very few real estate transactions, we haven't got enough tests to be statistically representative. So maybe we tested the 3 houses that are high out in West Kansas, and maybe we didn't. So some of the older maps, especially, they show a big hole in Nebraska. It's not that those houses don't test high, it's that there were only 10 tests out of each county, because when they made this map in the 90s, they made sure that they had at least 10 tests in every county in the country, which was quite a feat. So these are rules of thumb. You can always have a house test high. Even in Hawaii, where statistically it is less likely for houses to test high, there are houses that test high. So you got to test to know. It is the second leading cause of lung cancer after tobacco smoking. It is the leading cause of cancer death in the US as of 2020, but Dr. Giesi's data is much more thorough, so reference those. For radon-induced lung cancer in particular, we anticipate epidemiologically about 20,000 to 21,000 lung cancer deaths. It's actually 20 to 25,000 lung cancer deaths a year. Again, we can't stick you in a box, expose you to radon, expose your neighbor to less radon, and then see who gets it. This has to be done by the epidemiology from the healthcare system. The risk from radon depends on how long and how much. It's a dose issue. Obviously, there's some genetics that come into it. You all are probably well more versed in the cancer genetics. Smoking history also clearly plays a role because, as we know, smoking has a number of carcinogens in it. Radon is a single carcinogen. Let's see. So here's our map. Lung and bronchus is, of course, up at the top, outweighing everybody, but just by itself, never smoker radon-induced lung cancer is tied with leukemia, roughly, at about the 7th cancer cause of death, which is why we're here. So why is it that we care about both at the same time? Because it's multiplicatively increasing your risk for lung cancer to have exposure to high radon levels if you are also a smoker or an ever smoker. So when the EPA makes their charts, they make a never smokers chart, where we would anticipate about 7 out of every 1,000 persons would develop lung cancer. And an ever smokers, so whether you're smoking now or you smoked ever, that increases your risk to 62 out of 1,000 people could develop lung cancer over their lifetime. Because both have carcinogens, clearly tobacco smoking has many more carcinogens in it than radon, but they sort of cling together because radon itself is an inert gas. It doesn't stick to things, but once it has radioactively decays, it becomes a charged particle, and it can stick to the particulates in the air as part of which are part of smoking. And that's true even with vaping to an extent, because there are particulates that are released in the vaping process also. So when radon radioactively decays, so typically we breathe in the radon that is in a gaseous form. Most of the time we breathe it all back out. It hasn't radioactively decayed, nothing happens. But if it radioactively decays in our lungs, then it is near to living tissues and cells with DNA. And that activity, the release of the alpha particle, can chemically or physically break the DNA. Most of the time, our cells, because this is something we're exposed to across the whole planet, our cells fix all that. Sometimes that's not what happens. Sometimes they die, sometimes they fix it, and sometimes it damages the genes that cause tumor suppression, which is basically the definition of becoming cancerous, is not suppressing those genes. So we show this picture because this yellow dot with a bunch of bubbles in it. This is a tiny chip of plastic. One of the ways we measure radon is by exposing a very smooth piece of plastic to the air for a certain amount of time, closing it up and sending it to the lab. And then the lab literally counts how many pockmarks, how many bubbles are in the viewfinder. This is only exposed or magnified about 100 times. So you can see some of these marks with the naked eye if you have very good eyesight. But this is a 3-month exposure as the EPA action level of 4 picocuries of radon per liter of air. And so these are the marks that the alpha particles have left on the plastic as the radon decays in the air near to the plastic. So if they're making pockmarks on a piece of plastic, that is the way we visibly see what's maybe happening to the DNA structure in our living lung tissue. individuals with the GSTM1 are more at risk for having this damage not repaired. And that is the extent of my medical knowledge about this piece of information, but I can find I can find the reference if anybody is interested in how that functions. Radon is by far our greatest single source of radiation exposure. And this assumes that you're not having a regular medical dose of radiation, right? If you have to have a CAT scan for something else, or you're going in for other radioactive medical things, that increases your dose of radiation. But radon is the big red pie. So it's about 37% of your annual radiation exposure comes from radon, and that assumes that your indoor levels are 1.3 picocuries per liter of air, which is the average indoor level across the country. Understanding that, for example, in Kansas, a third of houses will be about 3 times that level. It'll be over 4 picocuries. So what do you do about it? Well, you test, you fix it, and hopefully downline we reduce our level of exposure and therefore our risk for lung cancer, developing lung cancer. Discounted test kits are available at K-State's extension offices across the state, in almost all offices. The Missouri Radon Program, if you're in the state of Missouri, offers a free kit for Missouri residents. If you're in Kansas, you must have a certified radon professional help you do this. You can always do it yourself in your own house, but we recommend you have a certified professional do it because it's a mechanical system that needs to be sort of calibrated for the house that it's installed into. In Missouri, they do not require that, but we certainly recommend that you use a certified professional in Missouri also. Reducing those radon levels is especially helpful for anybody who is also working to quit tobacco smoking, because it reduces the levels the same way it increases your risk on the other side. It reduces your risk for developing lung cancer as part of that experience. We can't undo any exposure we have previously had, but all of the time that you live in a house where the levels have been reduced is reducing your risk of going forward, and for everybody else who's living in the building, in the house with you. So doing, whoops, skipped way ahead. Sorry about that. Doing both together is more beneficial than doing one alone. The sooner you can reduce the radon exposure, the greater your risk reduction, because radon exposure, we are always talking about radon exposure over a lifetime, and over a lifetime in this case usually means in the whole 75, 76 year, 70, 80 year span of life. So anything you can do at any point earlier to reduce your levels is going to be a health benefit in the long term. I believe that some other folks are also going to cover this, but the Kansas Tobacco Quit Line is a great resource for Kansas. I assume that Missouri has a similar one, but I did not look that up. Sorry. And that those are resources for quitting once you have gone to quitting, or if you're working still on that, then next step would be to make use of your resources for radon testing and radon reduction.
Thank you, Christina. And yes, every state does have a tobacco quit line. That same phone number can be used regardless of what state a person is in, and that they can get connected to their own state's tobacco quit line, or you can find that online. Next, we have Brenda Stokes, who's the VP for Quality Improvement at the Community Health Center for Southeast Kansas, excuse me. Brenda's going to talk with us about a QI program project that her center has been working on to improve their lung cancer screening rates. Brenda, I will go ahead and advance to your first slide and let you get started.
Okay, thank you, Karen. So this slide just kind of summarizes our journey and the benefits that we've had. So we were honored to be accepted as one of the grantees of the Accelerated Cancer Screening Grant through HRSA, and which allowed us great partnerships with KU Medical Center and Masonic Cancer Alliance. It's through that partnership that we entered into the White Ribbon Project to assist us in the journey for lung cancer screening in Southeast Kansas. It has given us so much opportunity to educate our staff, develop patient awareness campaigns, and dramatically improve the number of patients that we have screened in Southeast Kansas for lung cancer. Can you go to the next slide, Karen? So a little bit about us and where we are. We are in the very southeast corner of Kansas. We also see patients from Missouri and Oklahoma because of our proximity to both of those locations. We care for more than 81,000 patients per year. We usually see about a 4 to 5, sometimes 6% growth each year to the number of patients that we serve. We offer medical, dental, behavioral health, pharmacy, school-based health and support services. We have over 1,000 employees now, and the map that you're seeing there, I know you can't see the small gray dots, but within that map, we have where our brick and mortar locations are, and then the light gray and dark purple color is where our patients are coming to us. So we submit zip code data to HRSA on our annual report, and this map is from the UDS Mapper, kind of gives us a good picture of where our patients are coming from. So while we don't have a brick and mortar building in Missouri, you can see that we are getting quite a few patients from the state of Missouri. We just recently, within the last year and a half, have a brick and mortar clinic in Bartlesville. We had seen some migration from the Bartlesville, Oklahoma area up into our Kansas clinic. So that's why we chose to get a clinic in Oklahoma. Forever growing. And then one last slide to kind of help paint the picture of where what we are. So this shows that we have our yellow stars, are our brick and mortar CHC primary care clinics with primary as well as walk-in clinics in most of those locations. The green with the little schoolhouse shows the clinics that we have in schools that have a provider, either part-time or full-time. The little nurse caps with the red cross shows that we have a nurse in the school in those areas. We are in 16 school districts. We also, over the last couple of years, have gone into correctional facilities. So the little black and white bars that you see there are where we offer primary care, primarily via telehealth in those locations. And then also we have community health workers helping those inmates as they transition out into the communities to help them become more successful. And then the green ribbons indicates where we have behavioral health also available in our clinics. We can go to the next slide. So our lung cancer screening journey. We, beginning in 2021 to 2022, began securing finances to get CT scanners in our clinics. We were successful in getting our first CT scanner in our Pittsburgh location in the fall of 2022, and then added a second unit in our Fort Scott clinic in 2023. We also, through all of our partnerships through the grant and with a lot of help from the White Ribbon and KU, offered educational series to our community health workers, our pop health specialists, and a lot of our other staff that outreach to our patients to educate them on Cancer 101, which covered all of our cancers that we see. We were also able to get a billboard, finance a billboard through some of our funding, which I'll share a picture of here in a little bit. We offered CMEs to our providers and helped develop lots of outreach materials. So pamphlets that we could send out to our patients and put on our tables at our outreach events, just to explain the benefits and the importance of getting screened for cancer. And then we also had several social media campaigns, and local television stations aired our CT, low-dose CT for lung cancer screening for us as well. Next slide, please. This is just a quick picture of our imaging department. The top one is our CT in Pittsburgh that was added in 2022, and the bottom one is the one in Fort Scott, and our happy diagnostic imaging techs. This is a picture of the billboard that was put up for us. We got quite a bit of traffic from that, which we were very fortunate to have. So over this journey, I wanted to start with lessons learned and barriers, and then I'll finish up with all of the successes and show you where we are. Our EMR did not support lung cancer screening as far as tracking and trending goes, because it's not a measure that we are required to submit at this time. So we have had to start at ground zero and try lots of different things. We built templates. We were able through the grant to hire a nurse navigator, so that a preventative nurse, so that all of the positive screenings for all of our cancers are routed to her, where she populates a template, and we're able to collect that additional information that we need. For lung cancer screening, though, we didn't have a good way of identifying that denominator. We still don't, but we're working towards that. It's very manual, which we all know that when you enter that human effect into it, we're not going to be 100%, but we're hoping to get to that point eventually. The screening questions for our low-dose CT, so we were finding that was a bottleneck for some of our providers, and so we needed to make sure that those screening questions printed on the order and actually was sent to our imaging department, so that those were already answered before the patient got there. So that's the ask order entry questions. And then the templates, as I alluded to earlier. So now the next slide kind of shows some of our successes. So we've increased awareness and education for all staff. We made the screening questions part of the order. We developed a self-referral, much like our mammogram self-referral. So patients that were able to see the ad on television could call us up and say, hey, what is this? And didn't have to see a primary care provider before they could come in and get their screening done. We developed templates to capture the PAC years history, because that is not something our EMR had a structured field in, so we have developed that. We've also developed lots of relationships with our partners, and have been able to sit in on a lot of educational opportunities through this grant. We started an internal tracking system in August. So from August 1st to present, we've had 122 normal screenings, identified 13 suspicious findings, and 21 required further follow-up. And our screening rates increased. So the next slide will show you the dramatic increase in that. So 2021 is where we started. The blue indicates orders that we're sending out to external facilities. So primarily in this area, it would be a CT at the hospital. And then the green, so you can see the fall of 2022 is when we added that first CT in October. So we had 11 internal, and then it's continued to grow. So as of the end of October, you can see we've ordered a lot of low-dose screenings for our patients. Thank you for listening to me, and here's my contact information. I'd be more than happy to share our successes and lessons learned if anyone would like to reach out.
Thank you so much, Brenda. And gosh, what dramatic changes you all have made in just a couple of short years. That's really excellent and so exciting to see. We can take a pause right now to answer questions, and I'm going to stop sharing my screen. I know we are running right up at the top of the hour, but as long as any presenters or participants would like to stay on, we can continue to field questions. And if presenters need to leave, we can always send questions and answers via email. Tracy, are there some questions in the chat?
Yes, there are. I know Dr. Gieske had addressed the secondhand smoking. Let me go through here, just to go back up to the top. I believe earlier in the session, Sarah from American Lung Association was kind enough to address the state of lung cancer report that was issued today and why lung cancer screening rates increased in this year's report. And she says that, in short, we changed the source of lung cancer screening data. And then she goes on to say, prior state of lung cancer reports use data on the number of lung cancer screenings from the American College of Radiology's Lung Cancer Screening Registry. However, since the requirement for screening facilities to participate in this registry in order to receive reimbursement from Medicare for screening scans was removed, the number of screenings reported by it has decreased each year. This year's report uses a new data source, the CDC's 22 BRFIS, the Behavioral Risk Factor Surveillance System, which included new questions allowing for the determination of screening rates by state. These rates were much higher overall and in every state, suggesting that the lung cancer screening registry did not capture a significant portion of lung cancer screenings.
See that there's a question from Susan, and I didn't look ahead to see if that question was answered, but I don't know if anybody wants to address the question about secondhand smoking compared to actually smoking, firsthand smoking. Dr. Gieske, I saw that you came off mute.
Yeah, I can answer that. I mean, that's always an important question. I'm always asked some question along that same line. What about family history, secondhand smoke, radon, air pollution, a lot of these things that we know are risk factors, but they haven't been approved by the USPSTF, which looks at all the evidence. And it's really important that we do screening within evidence-based guidelines, especially when we're talking about lung cancer screening, because we find a lot of these nodules that turn out to be benign nodules. And when you go after these nodules and you're putting tubes and needles and dye and scalpels into people's chest cavity, bad things can happen. So we have to be very discriminate in how we screen folks and how we go after these nodules. I think as time goes on, there will be risk models that consider secondhand smoke and these other variables that we know are important. AI will probably be part of the equation. There'll be more complex algorithms that determine an individual's risk for lung cancer and maybe how often the lung cancer screens need to be done. Not everybody needs to be screened every year, but that's the present state of affairs that we have to work with under. So it will change, it will improve, and we'll start reaching out and expanding our screening criteria.
And
Thank you.
I was looking for the paperwork because we have that a slide that addresses or puts secondhand smoke in the line with tobacco and radon, and it is by far fewer than the radon anticipated lung cancers over the year. I think it's 5,000, but I can't find, and that would have been data from the 90s or so anyway. So secondhand smoke is a risk, but tobacco smoking is so much worse or so much more risky. And radon is far more than the secondhand smoke also.
There's a question in the chat about vaping and its role in lung cancer risk. I know Dr. Gieske had to go. He had another obligation. And Catherine, I apologize because I do have some information about vaping and lung cancer risk, but I want to get you up-to-date information because I know that the research into vaping and its harms is rapidly evolving. And so I will be sure that we get an answer out to participants related to that question because I want to be sure that we have an opportunity to address it. And then there was some question. So Alice asks about how can a person who's not smoked qualify for screening? She grew up with parents who smoked and she's never smoked. And Alice, my advice always to people when they ask me that question is to talk with your healthcare provider. So either if you have an oncologist that you still are in contact with or your primary care provider to talk about your individual risk to see if they think that it makes sense for you to get screened and at what interval they would want you to get screened. So, the guidelines are the guidelines based on the general population, right? And so people with individual risk, people who are cancer survivors, right? There may be individual differences that make a difference in the decision about when and if a person should get screened. So it's a great question. I'm going to go ahead and pull our slides back up. One moment. Well, just a couple of reminders as we close out today. I so appreciate everybody's questions and participation today. And just a reminder that we will have office hours 2 weeks from today. We plan to have Dr. Gieske and Dr. Pierre Anda, who's one of the co-founders of the White Ribbon Project, joining us for office hours. So if you leave here today thinking, wow, we need to do more with lung cancer screening in my setting, please do join us. We plan to talk more about what kinds of strategies can help to put evidence-based practices to work in your setting. And so you can sign up again by clicking that QR code or using that bit.ly code that's office hours lung. You'll see that it is case sensitive again. So I'll leave this slide here for another 20 seconds or so. If you want to get signed up, go ahead and use that QR code. We'd love to have you. And if you miss it, feel free to just shoot us an email and we can get you signed up. Again, the reminder about continuing education credits, 52gent@eads.com, or by using the QR code, or you can text the activity identification code to that phone number. And please join us for the remainder of the series. So again, January 21st, February 11th, and then we'll have dates in March and May with some additional office hours sessions. So we hope to see you then. If you have colleagues or friends who you think, wow, they would really like to see this, have this information too in our future sessions, encourage them to join us so they can join with that bit.ly link or the QR code below. And we'll send these slides out so you'll be able to share that as well, because we'd love to have more people joining us. Thank you all very much for your time today. Sorry for keeping us a little bit over, and it's been really lovely to have you. I hope to see some of you on December 3rd. Take care.